Hi, I'm Dr. Tony Mork, orthopedic surgeon, endoscopic spine specialist. Today I'm going to talk to you a little bit about annular tears of the lumbar spine in particular. In my opinion, I think that annular tears are probably one of the most underrated and underdiagnosed problems, causing people have chronic low back pain as well as kind of their back going in and out over a period of months or years. So there's two ways to approach annular tears. One, it's a mechanical problem. These are loose disc fragments inside of the disc, and it causes pain as well as sometimes even pain down the legs. So the two reasons that people will often seek out care is because they have chronic low back pain that doesn't get better with time. It doesn't get better with physical therapy or other conservative measures. It does not respond to an epidural. And yet you can go to the doctor and they'll say, I don't really know what to do for you. Even if you have leg pain, you don't even have a disc herniation. So this is confusing. You go to people with quite a bit of back pain, but you actually will oftentimes see several doctors in the process of trying to get somebody to figure out what is hurting. So the diagnosis is almost always missing, as well as the cause for leg pain, because there's usually not a herniated disc with an annular tear. It's the chemicals from inside the disc that are stimulating the nerve that goes down your leg into your foot maybe, and this will give you the same pain as a disc herniation because it's chemically mediated, but there's nothing to see on the MRI scan, which confuses everybody. In any event, there's two ways to approach this particular problem. Since it's both a mechanical problem with fragments floating around the inside of the disc, and then the body is trying to mount a almost a defense or a situation where the fragments can be dissolved or reabsorbed. It's a long process and oftentimes not very successful. The chemicals that are actually generated are very inflammatory in nature, commonly referred to as bradykinin, cytokines, TNA alpha, are very, very inflammatory in nature, and this is what stimulates the nerves in the annulus. So this is a problem. You have both a mechanical problem as well as a chemical problem. Two approaches are, one, to endoscopically go in and clean out the disc. This does a few things. It mechanically removes the fragments, but it also can change the chemistry inside the disc. The other approach to this is actually just an injection, really what it turns out to be kind of a high concentration of dextrose as well as some lidocaine and some cortisone, which can actually also change the chemistry inside the disc. Typically, you'll have after the injection, you'll have pain initially for the first week or 2 weeks afterward, and at that point, the inflammation that the injection will give you will change the chemistry enough inside the disc so that the pain will start to go away, and maybe 65 or 70% of the time, it'll go away completely after a couple of weeks. Sometimes people will get the injection, the pain goes away almost immediately and never comes back, but this is a little bit more the unusual situation. In any event, it's not an epidural, it's actually an injection inside the disc. So most people don't really do this, and it can be very effective and a very easy and a conservative way with very low risk where people are getting fusions for this problem. Here's a simple to do injection with this kind of problem. Otherwise, mechanically removing the debris inside is oftentimes what I recommend, but sometimes it's not possible due to the anatomy where you cannot get an endoscope into the disc space, and then this is certainly something you could try as well. Here is a video of a gentleman who's about almost 50 to 55 years of age and has had chronic back pain for many years, aggravated by a car accident about a year ago. Pretty typical. Back pain, just a deep midline back pain which comes and goes, but just is always aggravated by sitting, not helped by physical therapy, not helped by any conservative measures. And we did the way to diagnose an annular tear, not by an MRI. They're not very good to discover the diagnosis of annular tear is not very well discovered with an MRI scan. The gold standard is a discogram followed by a CT scan, which can definitely show the leaking of the dye out into the disc space edges or even into the spinal canal. This gentleman had a confirmed diagnosis with the CT discogram, and he had a very tight lumbar 5 sacral 1 disc space, which I was unable to get any instruments into, and so I did an injection. And here he's giving a couple of responses, both maybe the next day as well as several days after the injection, and he's having a very good response. A little unusual. Most people have a little bit more pain, but in this case you can see that once the chemistry inside the disc is changed, that the pain response can be immediate, and he has really no pain, as you'll see here shortly. Probably one of the most typical findings on an MRI scan for adults in general is a disc bulge. So this is really almost a normal finding in very, most of the population, particularly when you get above 40 and 45 years of age. It almost means nothing. Everybody's got a disc bulge. But if you look into the literature, a disc bulge has the highest correlation of a symptomatic annular tear. So what isn't read as very much or very significant in terms of an MRI scan can actually be the most correlated finding on a positive discogram followed by a CT scan. So to have an annular tear on the gold standard, which is the CT discogram, actually turns out to be very well correlated with a disc bulge, which almost everybody has. So, but oftentimes these are not seen very well, or they're kind of ignored. People look at annular tears because not all of them hurt people. Only maybe a small percentage are disabling in nature. So there's people just assume that none of them hurt, but the fact is that some of them can hurt quite a lot and cause a lot of disability. In my opinion, annular tears are the #1 underdiagnosed cause of chronic low back pain. Yeah. So the lady that you're seeing in this particular video came in with chronic neck pain, and this is just chronic ongoing neck pain. And the challenge here is to figure out what's hurting. So in my approach to what I call spinal pain mapping, the thing is that you cannot just sedate a person and just put a needle in and go willy-nilly. I actually interview the patient. That person is awake on the operating table, and I'm able to push at various points in the neck and in the back of the skull, and this person will tell me exactly where it's hurting. At that point, I can put a little mark on the skin, and then with X-ray, fluoroscopic X-ray, I can tell exactly what portion of the cervical spine is hurting. In this case today, I'm looking for some facet pain, and I can identify which facets they were, which I can then mark, and then I have something to go for using a small needle to put some Novocaine and some cortisone into the joint. If she responds significantly and says, well, I have at least 80% improvement of my neck pain, I know that I have gotten to the correct pain generating areas or facet joints in this case, at which point then she would be a candidate for some type of laser procedure in order to obliterate the sensory nerves, the pain nerves. People say, well, can I hurt my arm, or are you near the spinal cord? No, these are small guiding joints in the back of the neck that give people a lot of pain and discomfort, and even can generate what they call cervicogenic headaches. So these are very annoying, and just anytime you turn your head or get in a certain position, you can either get neck pain or headache, and these can be taken care of just by actually lasering the soft tissues that are getting caught and pinched in the facet joints, as demonstrated by a paper I published back in 2010. In conclusion, whether we're dealing with chronic low back pain or we're dealing with problems with the neck causing headaches, the most important thing to establish is the diagnosis. You've got to have a good diagnosis before you go on, and a good diagnosis is the key to what I consider to be the ultimate in minimally invasive surgery, which is endoscopic spine surgery. A clear diagnosis is what allows you to get the minimum of surgery. Minimum of surgery is going to be it's going to be the minimum of soft tissue disturbance. You're not going to disturb any tissues that aren't involved with the problem, and it also really significantly diminishes any chance of overuse of narcotics postoperatively. These incisions are 3/8 of an inch. The pain from the surgery is gone in 7 to 10 days, and the problem is well on its way to healing with the minimum of disturbance of the other tissues that aren't involved with the problem. And so pain medications in this day and age of opioid concern and abuse is something that really doesn't last for any length of time. So I think that this is really the ultimate in minimally invasive surgery, a good diagnosis, and then treatment with the absolute smallest equipment possible.